Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Good morning. I am delighted to welcome you all today at our visiting professor, our lecture series with the title Quantitative Science in Public Health. There will be 3 lecture series, and the first series, this is a cohort study by Professor Sujata Khobragade from MMMC. Yeah. It is organized by Faculty of Medicine's Universitas Muhammadiyah Surakarta and Faculty of Medicine's Malaka Manipal Medical College. It is the second collaboration of Faculty of Medicine UMS and MMMC after our first collaboration in May 2020 in international webinar. First of all, praise and gratitude to Allah Subhanahu wa Ta'ala because of His blessing. We can join this virtually lecture even though we in COVID pandemics. My name is Dr. Nining Lestari. I'm from Universitas Muhammadiyah Surakarta. I'm from Department of Public Health and Family Medicine. It's pleasure to me as your moderator in this event. Before I go further, I would like to welcome our guest lecturer, Professor Dr. Sujata Khobragade. Good morning, Professor. Thank you for joining us today. I will also would like to welcome all students, lecturer. Thank you for joining us. Okay. Before we start, let me explain the rules during this virtual lecture. All participants should mute the microphone, but you still can activate your camera. You can deliver your message in the chat room or ask directly in the discussion session later. Okay, this agenda for today is after this introduction and then presentation from Prof. Sujata. After that, the discussion and finally the closing. The topic for this lecture section is a cohort study. Now we can begin. I would like to briefly introduce our guest lecturer. Prof. Sujata was born in Mumbai, India. Okay, Mas Agus, can you share the curriculum vitae of Prof. Sujata? Okay. Prof. Sujata was born in India and then his educational qualifier. Prof. Sujata finished his MBBS in Grand Medical College, Mumbai in 1983 and then in postgraduate diploma in maternal and child health in IGNOU University, Indira Gandhi National Open University in 2000. And then she finished his hospital management in Alagappa University in India too. Okay, next. And now Prof. Sujata is superintendent, what is called?
Chief Superintendent.
Oh, so yeah, Chief Superintendent of Examination, yeah, from 2008. And then Associate Professor in Malacca until now. Okay, that is a CV from Prof. Sujata. Okay, to our guest lecture, Prof. Sujata. The time is yours. It's about 50 minutes or more. It's flexible to you, Prof. Sujata. Okay, thank you, Prof.
Yeah. Thank you so much, Dr. Nining, for giving very good introduction. Now I will share my screen so that we can go through our cohort study. Good morning to all my students, lovely students.
Morning, Prof.
Good morning, Doctor.
Good morning. So today's topic is cohort study. I'm Dr. Sujata, Associate Professor from Department of Community Medicine, Malacca Manipal Medical College, Malaysia. What are we going to learn today in this lecture class is what is cohort study? Cohort study is sharing the same experience in defined time period with group of people. Whenever we are thinking of doing cohort study, we are having two groups. One group is study group, which is exposed to risk factor, and the comparison group will be non-exposure group. And then we are going to follow them up to find out which group is going to get the study disease, whatever disease we are going to study. For example, suppose if I am studying that there is association between smoking and ischemic heart disease. What I'm going to do is I will take the information of smoking. So my study group will be all smokers, comparison group will be all non-smokers, and I'm going to follow them up and find out which group of people are getting ischemic heart disease more. And then I can prove my research hypothesis. When to do cohort study? Whenever our population is willing to be in a study. Why do we say willing population is required for cohort study? Because cohort study is going on and on for 5 years, maybe 10 years, maybe 15 years, maybe 20 years. So the cohort study is very long study. It goes on for years together. Therefore, we have to say that the population is willing to be in our study because maximum attrition problem is seen in cohort study. What is the meaning of attrition? Attrition is loss of sample. Suppose if we start with 100 participants and in the end we are only having 90 people in our study. It means we have lost 10 people in our study. The loss can be maybe they have just changed their place, migrated. Maybe they have changed their occupation. Maybe they are no more in the study because of death. Or maybe we have educated them. Suppose as I gave you the example of smokers and non-smokers to develop ischemic heart disease. Suppose if investigator is going time to time to check ECG and say, oh, this person has not developed ischemic heart disease so far or myocardial infarction so far. So the person who is smoker, he will say, oh my God, this doctor is waiting for me to get heart attack. He quit smoking. Once he quits smoking, he is no more in our sample and we lose that particular individual. So attrition problem is maximum. So whenever we see that there is willing population, we will go for cohort. If we have lot of time and lot of money to conduct this study, we can go for cohort. And when you have good evidence of the association between two variables are independent variable and dependent variable. When we say independent variable, it is risk factor. Dependent variable is outcome of that risk factor, which will be disease. So when we say that there is association between these two variables, we will go for cohort study. What are the types of cohort study? Usually cohort study is prospective cohort study. Prospective meaning we are going to follow them up from cause to effect. We are going to see the risk factors. Suppose if they are already having the disease, they are not in our study design. They should be free of disease. Only what should be the feature? They should be exposed to the risk factor in our study group and no exposure to the risk factor in our comparison group. So we are going for prospective cohort study, but also we have retrospective cohort study where the exposure has already occurred and outcome is already there. It means disease has already occurred and now we jump into a past time to find out which group of exposed or non-exposed have developed the disease. So that is retrospective cohort study. Of course, I am going to give you in detail about prospective cohort study, retrospective cohort study, and I'll be giving you the examples. What are the advantages of doing cohort study is, even if we say it's time consuming, even if it's say it's very expensive, lot of ethical issues are there. The advantages, we can calculate incidence rate by cohort study. We can calculate relative risk with cohort study. When we say relative risk, it is the analysis for measure of association in cohort study. We can also calculate attributable risk factor. Attributable risk factor meaning that this is the risk factor causing these many percentage of the disease in population. And if we know that this particular risk factor is there for cause of the disease, we can prevent that, we can control that of so many percentage of the disease. So advantages, can calculate incidence, can calculate relative risk, and also calculate the attributable risk factor. With cohort study, we can do the study with multiple outcomes. As I gave you the example of smokers versus non-smokers, and I said that outcome is ischemic heart disease, but it is not only ischemic heart disease, we can also do the study on myocardial infarction. We can also do the study on COPDs because smokers are having the risk of developing COPDs or CA lung. So multiple outcome we can study with one exposure. So we can have the advantages of doing cohort study. Disadvantage, as I said, it is time consuming. Maximum attrition problem is there with cohort study. It is expensive. Lot of ethical issues are there. So disadvantages are also many, but advantages are much more. So we do go for cohort study. Bias in cohort study. What is the meaning of bias? Bias is systematic error occurring while conducting the study. Maybe it is due to selection bias. Suppose our sampling method is not correct. We are having sampling error. So there will be selection bias. Maybe our investigators collecting data, collecting information is having bias because they already know that this is study group. They will be collecting the data very carefully, and if they think that this is just a comparison group, maybe they are not so enthusiastic or not going in detail to collect the data because they already know that these are all non-exposed to risk factor group. Or maybe analytical bias, when statistician for his own advantage do some manipulation to get the good result, there can be analytical bias. So there are many bias in cohort study also, and we will learn how we are going to control them. And bias, we have to think about it before we start the study. Once the study has completed and then we come to know that bias has occurred, we cannot do because our estimation of the result can be underestimated or overestimated. So I'll talk about bias in cohort study in detail and also comparison between case control study and cohort study. I'll be telling you about a rough idea about all the epidemiological study, and then I will give you almost 10 points of comparison between case control study and cohort study. So let me tell you about epidemiological study. It is divided into interventional study, which is also called as experimental studies, and we are having natural exposure or non-interventional study, which is also called as observational study. When we say interventional study, we are talking about a randomized control trial. The intervention is given to the patients. Therefore, it is also called as clinical trials. We are having field trials where individual community member is involved in the intervention, and community trial when entire community is involved in our intervention. Observational epidemiological studies are divided into descriptive observational study and analytical observational study. When we say descriptive, there is no comparison group. We are just calculating magnitude and distribution of the disease. There is no testing of hypothesis. So the study they are falling in descriptive observational studies are case report, where one patient is there and one disease is there. Case series, where group of patients are there with one disease. We do have cross-sectional study where the data is collected at one particular point of time. And longitudinal study when we do follow-up of our study population. Analytical study is we do have comparison group. We have one group will be study group, other group will be comparison group. We are going to testing the hypothesis. Hypothesis is association between independent variable and dependent variable. And we have cross-sectional study, cohort study, that's what we are going to study today, which can be prospective, which can be retrospective or bidirectional. We started with retrospective study and then we continue it with prospective study that becomes bidirectional study. And we do have case control study. When we talk about cohort study, we are studying risk of exposure versus no exposure. In case control study, we are comparing disease people versus no disease. And case control study is always retrospective because outcome has already occurred. People are already having disease. And then we go back, take the past history and find out which group had got the risk factor. And we can conduct the case control study. So hypothesis is between association or relationship between the independent variables and dependent variables. Independent variable is the risk factor, dependent variable is the outcome. So what exposure is there, which is a risk exposure, and outcome will be our disease. And now we have to prove our research hypothesis that yes, there is association between these two variables. Cohort study is always marching towards outcome. It means it is going from cause to effect. Most of the time it is prospective cohort study, but as I said, it can be retrospective, it can be bidirectional study. Now, when we say what is cohort, group of individuals are sharing same experience within a defined time period. Example is occupational worker, if they are working in some chemical plant where they are getting exposed to that chemical, that is the risk factor, and the outcome will be cancer. With this chemical exposure, people may get the cancer. So those who are sharing the same experience, those workers who are sharing the same chemical exposure in that plant, and we are going to study with comparison non-exposed people. So we can just go to the same factory, we can take the exposed workers, those who are working in a plant, and the factory people, those who are not working in the plant but they are the officers working in the office, they are not getting exposed to that chemical. So we can go to the same factory, but comparison group we can select from same factory, those who are administrator, those who are working in finance, those who are salesmen, sales managers, or clerical staff, or any other staff which is not directly involved in the exposure to the chemicals. And then both the groups, we will follow them up to find out which group is developing the cancer. Maybe one specific particular cancer, maybe cancer bladder, maybe cancer esophagus, depending upon what is in our study. Or another example I can give is birth cohort. Now we already know about the milestones. How do we know? that baby can crawl at this month, baby can sit with support at this particular month, without support, can stand with support, without support, can baby walk, baby can run, baby can draw a line, baby can draw a circle, baby can draw a triangle. Now we are already know about the milestones of the babies. But first time they went for cohort study. Suppose 10,000 babies are born today and they have followed them up to see, check at multiple places that when the baby is doing all this. Now about the milestone. So this is the example of cohort. It is a study in which there is a comparison group of exposed to risk factor with no exposed to risk factor, and then we are going to find out the disease frequency in which group it's occurring more. There should be three features in cohort study. One is cohort studies are identified prior to appearance of disease. Suppose if the person is already having the disease, he cannot be in our study. So he has to be free of disease. Then we are having study groups. They are observed over a period of time. Period of time is a long time. Maybe 5 years, maybe 10 years, maybe years together to find out the disease frequency. And then we are comparing with the non-exposed people. And usually cohort is prospective cohort study, so it is going from cause to effect, going from risk factor to outcome, going from exposure to disease. So when to do cohort study? When we find that there is good evidence of association between the exposure of the risk factor with the disease. When there is rare exposure, as I gave you example of chemical factory. So chemicals imparted in that factory not affected to the general population. Only those who are working in that factory will be exposed to the chemical, the whatever the chemicals are exposed in that factory. So rare exposure can be done, the study can be done, and we can calculate the incidence in exposed people. And suppose if we think that incidence is high among this rare exposure, we can go for cohort study. If we see the winning population, because attrition problem is maximum in cohort study, so whenever we see that winning population is there, they are ready to be follow up for years together, they will be staying in the same place, they are not going to migrate to other places, they are not going to change their occupation. Whenever we see that minimize attrition problem will be there, we go for cohort study. And of course, lot of money is involved in cohort study. So before we start the study, we have to check our funds. We have to check our resources, because lot of human resources should be available. Lot of equipments, lot of places should be available. So for everything we have to pay. All the participants, maybe we require 10,000 people in our study. And whoever is coming in our study, we have to pay the participants. And once we are paying the participants, we have to have a lot of money, because 10,000 participants will be there in our study. So we have to find out about our funds, whether they are enough to do the cohort study. Now, being alive and free of outcome at the start of follow-up has to be there to do our cohort study. Now here just small picture. We have got one group is exposed. These are exposed but free of disease. They are unexposed and also free of disease. Now we are going to follow them up. What we see is at this stage, yes, exposed people are having more people with the disease compared to non-exposed or unexposed. If we keep on following them up for years together, what we see that this is the risk factor, they are exposed and they are having more people developing the disease compared to unexposed people. It means this is the risk factor to cause the disease. We can prove it by calculating relative risk, by calculating attributable risk. Now, when we are starting the study with exposed people, with non-exposed people, we are going to, I will tell you about 2 by 2 table. Right now, we will just learn this, that those who were exposed get the disease, we denote them by A. If people are exposed to the risk factor but did not get the disease, is denoted by B. And we are having comparison group which is unexposed to the risk factor. But still, if they get the disease, not because of the risk factor, but the particular risk factor which we are studying, but maybe other reason they get the disease, we denote it by C. No exposure, no disease, we denote it by D. So when I may prepare 2 by 2 table, I'll be explaining it further. We follow them up and then we do the analysis to prove our hypothesis. Now here another example. We are having cohort study. We are also having case control study and cross-sectional study. So when today I will talk only about cohort study, case control study and cross-sectional will be in our next series. Another lecturer will be taking this. So I'll just talk about cohort study. We are having 2 groups. The study group will be using oral contraceptive pills. The non-exposed people will not be using oral contraceptive pills. Maybe they are using some other contraceptive methods. And we will follow them up to find out which group of people are developing breast cancer more to prove our theory. So this is another example. Oral contraceptive pills versus no oral contraceptive pills. We'll follow them up for a period of time, maybe 5, 10, 15 years, and then we'll see which group are getting more breast cancer. Now, as I said, usually cohort study is prospective cohort study, which is going from cause to effect. But there can be retrospective cohort study or there can be bi-directional cohort study, combination of retrospective and prospective cohort study. So prospective cohort study is also called as concurrent cohort study. We are taking exposure group, we are taking comparison group, those who are not exposed to the risk factor. Now, observer is collecting the data in 5 years, 10 years, 15 years, like whatever you have decided that your study should be go on, maybe for 5 years only, maybe for 10 years only. So observer has started collecting the data and checking that who is getting the disease. This is called as prospective cohort study. When we talk about retrospective cohort study or historical cohort study, it is also called as non-concurrent cohort study. Here what has happened? Disease has already occurred. Exposure has already occurred. Now the observer is collecting the data, he is jumping back into time and collecting the data. I give you example here is, suppose if we are thinking of one chemical which is causing CA bladder. Now I go to that factory where the chemical is imparted. I take 100 workers of that chemical factory, those who are actually working in that chemical plant and they are getting exposed to that chemical. Same thing, 100 people I am taking from the office. They are not getting exposed to that chemical. As I said, I may be taking sales manager, sales director, maybe finance officer, maybe finance people, those who are working, accountant and all, maybe some clerical staff or any other staff, those who are working in the office and not getting exposed to the risk factor of that chemicals. So 100 I have taken workers, 100 I have taken officers. And now I check their medical record to find out who has got CA bladder. Suppose if among the exposed people, I find 10 CA bladder has occurred and among the officers, 1 CA bladder has occurred. Now I collect the data and I do the analysis. Suppose now I have taken 100 people here, those who were exposed to chemicals, 10 people have already developed CA bladder. It means 90 people have not developed the CA bladder. Now these 90 people and officers, only one person has developed CA bladder. It means 99 people do not have CA bladder. I continue to follow them up. That becomes bi-directional cohort study. I started with retrospective. I collected the data. I analyzes the data. I interpret the data. Now, once I have completed my retrospective study, I found that 90 people, those who are workers, do not have CA bladder. 99 people do not have CA bladder, and unexposed people, I follow them up for 5 years, 10 years, and whatever years I have planned to do the study and observe becomes bi-directional cohort study. So we have prospective cohort study, we have retrospective cohort study, and we have bi-directional cohort study. In prospective study, study is starting always before any outcome is there. And in retrospective study, outcome is also there, exposure is also there, and then we are doing the study. The data is collected when outcome is already occurred. And we are jumping back in time. We are taking the medical record or maybe death record, maybe health records from the hospital, from the companies, and we are jumping back in time to do the study. So as I said, it can be prospective, it can be retrospective. Prospective is going from cause to effect. Retrospective, exposure has already occurred, outcome is now we are jumping back in time. We are doing retrospective cohort study. And if we find some people, those who are still free of outcome, we follow them up, becomes bi-directional study. You all can jot down your questions if you have any. During discussion part, I will try to explain as much as possible with some different examples. Now here I have got one small video clip. I am starting it, but please one of you unmute and let me know whether you can hear this. If you cannot hear, I will talk it out, okay? Now, can you please tell me whether you can hear this or no?
Not yet, Prof.
Okay, so what I will do is I will just make the speaker at 0 volume. Sorry. Yeah. Now I will just talk it out instead of him talking. Okay. So now here we are talking about cohort type studies. We have taken one exposed group and another non-exposed group. We are going to follow up both the groups and we are going to compare the incidence of disease in both the groups. Now coming to prospective cohort study, we are doing the study when people do not have the disease. Here we are going to see the outcome is heart disease in women. So we are going to enroll the disease-free cohort. It means if we are studying about the heart disease in women, they should not have heart disease at the starting of our study. Now here we have taken all nurses. How many number? 117,000, and we are taking them without any heart disease, coronary vascular disease. And we are going to follow them up. So what we have done is we have divided them into all the nurses. We have taken 117,000. We have divided them into obese and lean. So we want to prove that there is association between obesity and heart disease. What is heart disease? We are seeing is only coronary vascular disease. All right. So we are going to follow them up and find out the incidence of heart attack among obese nurses, among non-obese or lean or normal weight nurses. Now, after time has elapsed, investigators use the prospective collected data to answer the question. So, we are going to do the analysis. We are going to calculate relative risk. We are going to calculate attributable risk. Of course, about analysis, I'll be telling you in detail how do we calculate. I'll give you the formula to calculation, and I will ask you to practice also so that you know. I have already given you the exercises. So we can, if time permits, we will discuss the exercises also. So in prospective, what we have done is we have taken people without any disease. We have divided them into the risk factor of obesity versus no obesity or normal weight. We are depending upon the calculation of BMI. We have divided them into two groups, and we are going to compare. We are going to go follow them up for years together to see which group is getting the coronary vascular disease or heart attack. Now, whenever we talk about prospective cohort study, it is pre-planned. We have already planned how many people we require, how many obese people we are dividing them in the study group, how many normal weight people we are dividing them into the lean group or comparison group, and this is all pre-planned, pre-designed. So prospective cohort study, usually we are able to do it very nicely. Only thing we have to take care of attrition problem. Otherwise, it is very well designed, most informative study design. So now, if we jump back in time, it means we are doing retrospective cohort study. Prospective study was pre-planned, pre-designed. We were having time to take the 117,000 nurses. So we have already well planned, well designed who will be calculating BMI, who will be deciding that they are obese after calculation of BMI, who will be taking normal weight nurses. So all this was pre-planned. In retrospective cohort study, we are here studying the chemicals used in manufacturing tire, which will increase the risk of death. So now, what is happening here? We have taken the employees of tire manufacturing company, and we are going to take or see the health record of the workers who are directly getting exposed to the chemicals in manufacturing tire. Oh, sorry. I'm sorry. So, because this I'm doing manually, I'm so sorry for this. If the sound is proper, everybody could see, then the speaker would have talked about it. Now we have divided into two groups. Exposed group, those who are actually manufacturing the tire, and unexposed group, those who are not in the factory, they are in the offices. Now we are going to compare the death records. What do we see? That those who were exposed to chemicals were more in number in death record compared to unexposed group. So what we have to see is that this study was not pre-planned. The data has not been recorded as per your study. They are not getting the pre-edited data. Whatever was available, they have taken the data and they have concluded the result. They have done the analysis. So retrospective design cohort study is not pre-planned. It is not pre-designed study. And we are just going to see maybe the follow-up incomplete. Maybe the record is not given completely. So the result may not be so accurate as prospective cohort study. So here what they have done is they have compared prospective cohort design or study with retrospective cohort study. Prospective cohort study is going in the direction of cause to effect. There is no disease has occurred. It is pre-planned and pre-designed. Compared to retrospective cohort study design, which is jumping back in time, and we are just taking the medical health record or death record or any existing data which is not pre-designed, which is not predetermined. We are just going to take whatever data is available. So we are having retrospective cohort study, we are having prospective, but usually we are doing prospective cohort study. And it can be bidirectional also. Now coming to selection of the cohort study people. One group will be study cohort, which will be exposed to the risk factor. The comparison group will be not exposed to the risk factor. And when we are selecting the study or exposed group, we are taking the data on exposure. Then we follow them up. Both the groups are followed up, and then we do the analysis. Now, when we have to select the study cohort, it means we are selecting the exposed group, exposed to the risk factor. It can be from general population. Suppose if exposure is very frequent, like as I said, if we are studying about the smokers, suppose if we are studying about the alcoholics, suppose if we are studying about the pollution, maybe it is available in general population. So we can select the study cohort from general population or maybe from special group. As we said that only people, those who are working in the chemicals of manufacturing tire or manufacturing paint, or those who are working in agricultural farm where they are getting exposed to insecticides while maybe spraying it. So they can be a special group. Or maybe some professional group, occupational wise, maybe doctors are getting exposed to HIV patient, or nurses are getting exposed to HIV patients, or hepatitis B patient, or some special professional groups, those who are getting exposed. So we can select depending upon our study from general population or from the special group. How are we going to obtain the data on exposure? Maybe by personal interview, maybe we are emailing the questionnaire, maybe we are reviewing the records on dose of drug, radiation, type of surgery, depending upon what study we are doing. Or maybe medical examination or special test, maybe environmental survey by obtaining the data of exposure. We can classify cohort as exposed and non-exposed, or maybe we can subclassify. Suppose if I take all smokers, but I subclassify them as light smoker or heavy smokers. So there can be internal comparison. Maybe I take everybody who is doing exercise, but can be do some people are doing light exercise or some people are doing vigorous exercise, so internal comparison can be there. So we have external comparison where we are taking exposed group versus non-exposed group, or we can take internal comparison where we can subclassify them with the light exercise or vigorous exercise, light smoker or heavy smoker. Now here I have done internal comparison. I have subclassified them into light smokers versus heavy smoker. The age standardized death rates per 100,000 men per year by amount of current smoking. So if I see light smoker, those who were smoking less than half a packet of cigarettes, we see death rate is only 95.2. If we compare with heavy smokers, those who are smoking more than 2 packets of cigarettes, the death rate has increased tremendously. We see 264.2 death rate among heavy smokers. So we can do internal comparison. We can do external comparison where all are smokers in study group, all are non-smokers in our comparison. And then we want to find out which group is getting the disease. Then comparison with general population. Suppose if the comparison group is not available otherwise, we can also take them from the general population. The comparison group here is example given, cancer rate of uranium miners. So uranium miners are getting exposed and we want to find out whether they are going to develop cancer. Comparison with the general population, how many people are getting the cancer rate. So we can do that comparison, or mortality experience of exposed group versus mortality experience in general population. Now we are going to follow them up both the groups properly to obtain the data on morbidity or mortality. Regular follow-up of all participants. I have written here 95% because attrition problem is surely there because the study is going on and on for years together. And in the end of our study, not all the participants are available. Maybe few participants are already not available for the collection of data. We can do medical examination for follow-up, we can take hospital records, we can take death records, and we can take questionnaire. Just email them. Maybe nowadays we are also having Google questionnaire, Google forms. We can just type our questions in Google form and ask them to do. We can do the get the answers from there. We can have telephone calls or maybe some periodic home visit to follow up the groups, both the groups, whether they are exposed group or unexposed group. Now attrition, I already told you what is attrition. Some loss to follow-up is inevitable, maybe because death has occurred, maybe change of address, maybe migration has occurred, maybe change of occupation. Loss to follow-up is one of the drawbacks of the cohort study. It is surely going to occur. Now coming to analysis. Incidence rate of outcome, relative risk, attributable risk and population attributable risk. I'll tell you one by one. First of all, how to make 2 by 2 table. There is a rule. The disease status has to be up and exposure status has to be on left hand side of the table. This is a must because we are going to denote it by ABCD and the formula will be depending upon this ABCD. So suppose if disease has occurred because of the exposure of risk factor, we denote it by A. If exposure has occurred but there is no disease, we denote it by B. So all the exposed people will be denoted as A plus B and we call it as steady cohort. All these people are exposed to risk factor. Non-exposed or unexposed people, but they still have developed the disease, we denote it by C. If no exposure, no disease, we denote it by D. All those comparison group who were not exposed to the risk factor is C plus D. All the diseased people are A plus C. All the no diseased people are B plus D. And N is number of people, those who are attending your study. So they are A plus B plus C plus D. This is our 2 by 2 table. Once we know how to make this 2 by 2 table, it's very easy to analyze it. As I said, in cohort study, we can calculate incidence rate. So what we do, we calculate incidence of disease in exposed group, incidence of disease in non-exposed group. So we are going to calculate number of diseased people in exposed group divided by number of subjects in exposed group. So number of subjects in exposed group who develop the disease, we denoted it by A. Number of subjects in exposed group were A plus B. So our IE is incidence of disease in exposed group will be A upon A plus B. Unexposed group is also, we denote it by IO. Number of subjects in non-exposed group who developed the disease was C. All those people who were not exposed were C plus D. So IO will be C upon C plus D. Now suppose if now we don't have too much of time, otherwise I would have given you to calculate the incidence of disease among smokers, how many of people have developed CA lung because of smoking. We have to calculate 70 upon 7,000. And IO, those who were non-smokers but developed CA lung, 3 upon 3,000. So I will calculate this for you now, 10 per 1000. Later on you can just see, I have already sent the PowerPoint also and exercises also, so you can calculate on your own. Incidence of CA lung among non-smokers is 1 per 1000. So IE is 10, IO is 1 per 1000. Now how do we calculate relative risk is? Incidence of disease in exposed group, we had denoted it by IE. Incidence of disease in non-exposed group, we have denoted it by IO. So relative risk will be calculated A upon A plus B divided by C upon C plus D. That will be our formula for relative risk. Now we had calculated this. IE 10 per 1000, IO 1 per 1000. So our relative risk will be 10 upon 1 is equal to 10. So whenever we are calculating, please do not forget to interpret your result. Because suppose if you are publishing the paper and you say, okay, I found relative risk 10. How do audience or reader will know that what is the meaning of 10? So please write down your interpretation. The incident rate for lung cancer is 10 times higher in the smokers compared to non-smokers. We have to write down the interpretation. And how do we interpret? Now we will ignore OR. OR is odds ratio, which we use it in case control study or cross-sectional. Relative risk, the measure of association, we use it in cohort study and when we do RCT. So right now we'll just focus upon RR. RR is relative risk. Suppose if your answer is 1, it means risk in exposed is equal to risk in non-exposed. It means there is no association. If your RR is more than 1, it means risk in exposed is greater than the risk in non-exposed. It means we have positive association. These many times greater chance of developing the disease among exposed compared to non-exposed. If your relative risk is less than 1, it means risk in exposed will be less than risk in non-exposed. It means not negative association or maybe protective factor. Suppose if I am doing RCT and my exposed group will be vaccinated people, immunized people versus non-vaccinated or unimmunized people. My result should be less than 1 because I want to prove that if people are exposed to vaccination, they will get less disease compared to unimmune people or unvaccinated. Now, what is risk difference or attributable risk? It is nothing but IE minus IO. Whatever incidence of disease has occurred in exposed minus whatever disease has occurred in incidence of disease has occurred in non-exposed. So we have got the answer 10 and 1. Attributable risk will be 10 minus 1, which is equal to 9 per 1000, and our interpretation will be 9 out of 10 per 1000 cases of CA lung among smokers are attributable to their smoking. Because they are smoking, they got the disease. Now suppose if we have to calculate it as proportion. Attributable risk as proportion we will be calculating as IE minus IO upon IE into 100. We are saying 100 because we are calculating the percentage. So whenever we multiply by 100, it means we are giving answer in percentage. So now we have already got 10 minus 1 upon 10 into 100. Our answer is 90%. So 90% of lung cancer among smokers are due to their smoking. This will be our interpretation. Now relative risk is measure the strength of association. It is important in etiological study of the disease and whenever we want to find out the cause, we are doing calculating relative risk. Attributable risk is important in prevention because now we know already that 90% of people are getting the disease because of their smoking habit. So if we make some preventive measures to control smoking, we can actually prevent 90% of the disease in population. Now this is just example of lung cancer and coronary heart disease, mortality in male British physician, smoker versus non-smoker. So it's nothing, we are just seeing lung cancer among smokers, coronary heart disease among smokers, lung cancer among non-smokers, coronary heart disease among already relative risk is calculated, attributable risk is calculated. The study was done by Doll and Hill in 1951. The participants were British medical doctors and number was 59,600. This is just to show that how many people we require to do the cohort study, and the study went on for 4 years and 5 months. It means the study is very, very time consuming and also expensive. Now advantages, we can calculate incidence rate, we can calculate relative risk, more than one outcome can be seen by single exposure, dose response ratio can be calculated as I shown you, light smoker versus heavy smoker. Cause effect, temporal relation. Temporal relation is nothing but the time taken from the exposure to the outcome. We can calculate it because most of the time cohort study is prospective study. Rare exposure, we can do the study. Minimize misclassification bias of exposed and non-exposed. No recall bias because we are going prospective. We are going from cause to effect. And most definitive information of the three analytical study. Other two are cross-sectional and case control. But disadvantages are not less. Many disadvantages requires large sample, not suitable for rare disease. It is suitable for rare exposure, but not suitable for rare disease. If we are doing any study on rare disease, we choose case control study design, but not cohort study. Attrition problem is maximum, time consuming, expensive, needs more manpower, ethical issues, and concentrate to limited number of exposure possible related to outcome. Selection of comparison groups representative to exposed and unexposed groups in general population, it is difficult. So sampling method becomes sometimes difficult in these cases. And study itself educates people and alter behavior. As I gave you example, if we are studying smokers and the outcome is myocardial infarction, every time, every 1 month, we are taking the ECG and we are getting, oh, until now, no heart attack, no heart attack. And when our participants hear this, that the investigator is waiting for us to develop heart attack, they quit smoking. So sometimes once they quit smoking, they are no more in our study. So we have already educated them and attrition problem will be more. Coming to bias, bias in assessment, we can prevent it by masking the investigators. Information bias occurs if the quality and extent of information obtained is different. We will be taking care of collecting the data very carefully. Bias from non-response and losses to follow. Suppose if we are doing some study, exposed versus non-exposed, and in exposed groups sometimes people are no more there because they are already dead. Death has occurred. So what happens? We are taking the data or the history or whatever the things we are asking to the relative of the person who was exposed to the risk factor. So maybe we are not getting or collecting the proper data because data given by comparison group, they are alive, they have not undergone any risk factor, the person who is participating in the study. But exposed group, because he is dead and you are taking the data from maybe sibling, maybe from parents, maybe from spouse, maybe from children, the data will not be very correct, accurate as if otherwise would have happened. So therefore, the bias can be in selection of your sample. Bias can be when you are collecting the data, information bias, or can be analytical bias when the calculation is not done correctly. If we already know that this is the study group, this is the exposed to risk factor group, we may get bias that, oh, they must get more disease compared to non-exposed group. So sometimes they do variation in the thing, they adjust or they do something which may go wrong. So we are actually blinding it. When we are giving it to statistician, what we do is we do not inform them that this is the study group data, this is the comparison group data. We just say group A, group B, group N, group Y, anything like that which will not give any clue which group is study group, which group is control group. Now I think this will be my last slide. So we'll go very quickly. I have already taken one now. So case control study goes from effect to cause. It means disease is already there and you want to find out the etiology. Cohort study goes from cause to effect, exposed group is there, risk factor is there, and now we are going to find out the outcome. Case control starts with the disease. We take disease group compared to that control group which does not have disease. Cohort study starts with exposure. We are taking exposed group versus unexposed group. Test whether suspected cause occurs more frequently in diseased people than control group in case control study. Test whether disease occurs more frequently in exposed group. Few number of subjects are required for case control, large sample is required for cohort study. Because less number of subjects are required in case control, results are quick. Time taken by case control is less compared to cohort study. Long follow-up, so the result also gets delayed and also study goes on for long time. Case control study can be done on rare disease, cohort study can be done on rare exposure. The measure of association for case control study is odds ratio. Cohort study, we calculate relative risk and attributable risk. We can study association of disease with several exposure. In cohort study, we can study the association with several. One exposure, multiple outcomes. Case control, relatively inexpensive. Cohort study is expensive. The most expensive study is cohort study. Most time consuming study is cohort study. More or maximum problem of attrition is with cohort study. Temporal relationship is hard to establish with case control because outcome is already there, and now we are jumping back in time to find out the exposure related to that disease. Very difficult to calculate temporal relationship, but cohort study, temporal relationship is easy to establish. So with this, I finish my PowerPoint. Now time for question answer.
Thank you, Prof. Sujata. Now we are going to discussion session. Okay, we have detailed information from Prof. Sujata Khobragade about the cohort study. Okay, student, you can ask directly. Raise your hand and mute your microphone and ask directly. Don't forget to mention your name. Okay, thank you. Okay, any students? Oke, ada yang bertanya, adik-adik? Silahkan, oke. Silahkan, ada yang bertanya? Okay, maybe I want to ask to Prof. Sujata. Yeah, there is a retrospective cohort, and it is familiar with case control because of start with the disease. Yeah. So, what is the difference in this cohort retrospective and case control? Okay.
Thank you, Dr. Nenning. It's a very good question. Actually, my students also, most of the time, they start with this question. Yeah, many students are getting confused because of retrospective. So I will make it very clear that whenever we are doing retrospective cohort study, our comparison group is non-exposed to the risk factor. Whenever we are doing case control study, our comparison group is non-diseased people. So I give you example. Suppose if I am doing retrospective cohort study, what I do is I am taking exposed group. Exposed group, I give you the example of chemical exposure while manufacturing tire. And my comparison group was all those who were not getting exposed to the manufacturing of tire. They are office people or any other people, but not getting exposed to chemical. That becomes my retrospective. because now already outcome is there. My outcome was, I was thinking that the chemical which is imparted while manufacturing tire is CA bladder. I'm just giving one example. So I'm not taking CA bladder versus no CA bladder, but what I'm taking is exposed versus non-exposed in my retrospective cohort study. But suppose if I'm doing case control study, I will be taking my study group as all CA bladder. All 100 people will be having CA bladder. All 100 people in my comparison group will be without CA bladder. Either they are healthy or they are having some other disease but not CA bladder. And now I am going to find out how many of them were working in chemical factory. Among those who have got CA bladder, those who do not have CA bladder. It is that maybe some people, those who do not have CA bladder, also have got exposed to chemicals while manufacturing tire. So our comparison group is different. In case control, comparison group will be disease versus no disease. It means we are comparing A plus C versus B plus D. In retrospective cohort study, we are comparing A plus B versus C plus D. I hope this is clear. If any more example, I am ready to give.
Okay, it's very clear. So there is
Here.
disease, yeah, from disease, and then we wants to know the exposure. We can use cohort or we can use a case control. Yeah, if we use disease from disease, we use case control, right? Okay. Okay. Any questions from students? Okay, silakan.
Excuse me, Prof. I want to ask two questions.
Okay.
My name is Zaid. I want to ask if we look on your explanation, how do we differentiate from experimental study? Because in the part of study, we provide exposure.
Yes. Very good question, Dr. Zaid. I know now, future doctor, okay.
Medical
Yeah.
phase.
Yes. Yeah. So, experimental study, when we are doing it, we are giving intervention. Cohort study is observational, where the exposure is natural. We are not intervening. So when we talk about experimental study, there is intervention by the researcher. So we are taking the study group who will be receiving intervention. Maybe when I'm developing newer drug, so my study group will be receiving that newer drug versus control group. Control group will be given either placebo or maybe nothing. Usually we give placebo because we don't want any participant bias. If we don't give anything, already control group know that they are in control group. And if they are receiving, they already know that they are intervention. So the difference is very easy between experimental and cohort. So I don't think there should be any confusion. Intervention is given by the researcher in experimental study. In cohort study, the exposure is natural. It is observational study. All right, Zaid, I think I answered your question.
Okay. So if like what you like when you give the example, when the participant is smoker, if the smoke if is given from the researcher, that is experimental study.
No, this will
No.
be unethical study.
Oh, unethical study.
This is unethical. We cannot say all non-smokers because my smoker group is small, please come on, start smoking. It is unethical. So any harmful substance you cannot go for experimental study. Always, whenever we are going for experimental study, it is going to reduce the suffering of human beings. Okay. So please don't do that.
Okay.
Yeah.
Thank you, Prof. Okay, my second question.
Yes.
Is there is a minimum time limit for conducting the cohort study?
Usually, sorry. Anything you want to ask?
No.
Okay. Usually, it depends upon what disease we are thinking of. The risk factor is, as you said, we are going for smoking versus non-smoking. Then what we do, suppose if my outcome, I'm thinking about association of CA lung. So CA lung is not going to occur within 1 year. The smoker is how many cigarettes he's smoking, for how long he's smoking. So we are talking about dose also, we are talking about duration also, and usually how long it will take to develop CLM. So we are going for the study maybe for 10 years, maybe for 15, 20 years. But suppose if my study design is for the outcome, I'm thinking about ischemic heart disease, not even myocardial infarction. I'm thinking when he's going to develop ischemia. So what will happen? I am taking smokers, I am taking non-smokers, and my study maybe I'm doing with heavy smokers versus light smokers. So heavy smokers, maybe within 1 year, maybe within 2 years, he may develop. So I can decide, okay, my study design will be only for 3 years. And I see whether heavy smokers are developing ischemic heart disease more in number compared to light smokers. Okay. So our this duration of study design depends upon what outcome we are looking for. Okay. Am I clear?
Thank you, Prof. Sujata. So
Okay,
there is
thank you.
no minimum time limit.
No minimum time limit.
Thank you.
Yeah. Okay. Okay. Thank you. Thank you.
Right. Okay, next questions.
Excuse me.
Yes.
My name is Safitri Srihandayani. I want to ask which one is better between a prospective cohort and a retrospective cohort study. Can you help to explain it? Thank
Yes.
you.
It is always prospective cohort study design, which is the best. The best, I will say. Okay. Why? Because we can calculate the temporal relationship also. Temporal relationship meaning we are going to calculate the time taken from the exposure till the outcome. In prospective cohort study design, it is pre-planned, it is pre-designed, it is predetermined. It means most of the things are under control of researcher. I will be taking, because I am taking first the history of smoking. So if I think that, okay, this person, maybe he's smoker, but he says I'm not smoking and want to go in non-smokers, I can ask him to leave my study, right? I will say, okay, actually he's smoker and he wants to be in my study among comparison group. So everything is in researcher's control. So always to get cause effect relationship, that is temporal relationship, to do not go for recall bias. We also have one of the biases, recall bias, because we are taking past history. Maybe they do not remember, maybe the memory bias, maybe there is differential classification of the bias. Differential classification meaning the study group is giving us very correct answer because they are the sufferer. In retrospective, outcome is already there, right? Suppose if I give you the example of mothers delivered congenital babies versus mothers I'm taking all NCs, right? I'm taking all NCs because now these people will be remembering, because they have delivered congenital babies, they will remember the entire ANC. All 9 months they'll remember because they have delivered congenital baby. Suppose if you ask the history, those who have delivered normal babies, they will not remember very correctly. 1 month I did, first month what I did, third month what I did, what I ate, what exercise I did. But congenital delivered mother will remember, oh, I took one paracetamol in my first trimester. Maybe she will remember so clearly because now she's so nervous, she wants to follow up the event. So retrospective will go in behind the time you are taking past history. So I think these many examples are enough. Dr. Saiftri, please unmute your mic so that if you are asking me anything, I can hear you. Unmute.
Sophia?
Unmute.
I think it is clear.
Okay, okay, thank you.
Yeah.
Okay, thank you. Thank you.
She said, it means yes. Clear.
All right, okay, thank you so much.
Okay, next question. Okay.
Professor, I would like to ask a question.
Okay.
And from what you've explained before, there are some bias in cohort studies, and one of them is analytic bias.
Yes.
And I would like to ask a question on what kind of analytic bias is it, and how can we solve it and try to avoid it when we start our studies. Thank you, Professor.
Okay, thank you so much, Yuditya. Actually, analytical bias occurs when we are hiring statistician, because this data is not simple, not very few number. It will be in thousands of number. So what usually when a person is going for cohort study, we are hiring statistician, and we make it very official that the data analyst is doing our data. He is analyst. Now, because you're hiring, you are paying them. And if you think that the data analyst or statistician is getting paid, he may be like maybe thinking that let me give a good result. It's not always occurring, but it may occur very frequently. So what will happen if you are saying this is the data of my study participants, this is another data of my comparison group. He want now because as a researcher, I want to prove my association between the risk factor and the outcome. And the statistician will say, okay, these people were exposed to the risk factor. These people did not get exposed to the risk factor. So the comparison group, I will just say, no, okay, they are not having so much disease, because now thousands and thousands of data is there. So manipulation can be, not manipulation, I should say, adjustment of the data can occur. And your result will be overestimated because of the adjustment of the data. So if the data analyst or statistician already know that these are the people who were exposed to this, he will say, okay, they have developed disease by adjusting his data. So that is called as analytical bias. All right, is this clear?
Thank you, Professor.
Terima kasih, Yuditya. Thank you, Professor. Okay, next question.
Excuse me, I want to ask a question, Doctor. Okay, in your in Professor slide there is so many disadvantage of cohort design, and one of them is cohort is not suitable for rare disease. My question is why that is not suitable for rare disease, and if we want to observe the rare disease, which design can we use for better? Thank you, Prof.
Okay, thank you, Dr. Nafi. It's a very good question. See, when we are doing for rare disease, our cohort study design is exposed versus non-exposed, and not disease versus no disease. So if rarest disease is there, maybe you are thinking that this risk factor has caused, but it is very rare. So how long you will go on to wait for that disease to occur? Because it is rare. It is not frequently occurring in a population. So your second question is, which study design you will choose if the disease is rare is case control. Because rare disease has already occurred. You are not waiting for it to occur. So if you are having rare disease, you can call all those who got the rare disease in your study group versus no disease at all in your control group. So your study design will be case control instead of cohort. All right? Is this clear for you, Dr. Nafi?
Yeah, very clear. Thank you, Professor.
Yeah. Thank you.
Okay. Maybe questions from a student from MMC. I will give you time to ask. Okay. Our next questions. Silakan.
Assalamualaikum warahmatullahi wabarakatuh, Profesor Sujata.
Yeah.
My name is Rahma Pranesti. It is my honor can hear your lecture today. On your explanation, you said some loss to follow up is inevitable due to death, change of dress, migration, change of occupation. The question is, what should we do? Should we find a replacement? When we're looking for a replacement, should we start from the beginning of the research? Thank you, Professor Sujata.
Thank you, Dr. Rahma, for asking very good question. Whenever we are doing cohort study, we in the beginning only try to take willing population. Second thing, the sample size is huge, very large, so that even if 5% people have dropped your study, we can still continue. The second question is whether you can replace. So we cannot replace. And we cannot go back again. Suppose if after 2-3 years some people have dropped out because they are no more in the world, or maybe they have left the place where you are doing the study, they have migrated to some other place, we cannot replace that. Okay, so replacement is not available, and 5% of attrition is taken as all right. Even if you start with 95%, it should be. So 5% attrition is okay. All right. So Dr. Hema, are you okay with my reply, or you want some more explanation?
Okay, Professor. So there are a lot of dropout on this research.
Yeah. More than 5%, yes, we have to stop the study. We cannot go further.
Okay, thank you, Professor Sujata.
Okay. Next questions. We have 10 minutes left. Okay. Next questions. There is questions. Students.
I want to ask, Mr.
Okay, silakan.
Okay, maybe when we want to choose, for example, smoking as our risk factor to do cohort study, but it is possible for one person they have more than one risk factor, like maybe one person they do smoking and drinking alcohol, but the other they are just smoking. So can it become bias to our study result because there is some other factor that also affect the develop of the disease, but we don't concern about it.
Thank you, Dr. Iqbal. It's a very good question, because when we are talking about bias, we should not forget about confounders. What is the confounder? Is the third variable which can affect our results. Either you get overestimation of the result or underestimation of the result. So suppose if my study is on alcohol with C. esophagus and my participant or my study group also smoker, what will happen? Because smoking can also cause C. esophagus. Even if he was not alcoholic, only smoker, also he was at risk of developing C. esophagus. So we have to take care of this confounding factor. So suppose if my study is with smokers and he's also alcoholic, which will affect my outcome, I am not taking that participant. So once you are starting the selection of your study group, you have to take care of confounders. All right. So there will be big no for alcoholics. We are taking only smokers, but they are also alcoholic. But this alcohol may also going to be interfering with my outcome. He will not get selected in my study. Is clear?
Okay. Uh,
Thank you.
okay. Maybe two questions more. Next questions.
Saya izin bertanya, dokter.
Oke, silakan.
Baik. Good morning, Professor. My name is Fahri Nafaldi, a medical student of Muhammadiyah University of Surakarta. Permit to ask the Professor, regarding what has been explained before, that when we do cohort studies, one of this is rare exposure and incident is high. My question is, what the example for that rare exposure and high incident? And secondly, my question is, before you said before, need long time to these studies. Yes. How long should it ideally take? 1 year, 5 year of there is no limit, but how long ideally take the long time to do this research? Thank you, Prof.
Okay. Thank you, Dr. Fakri. It's a very, very good question, and everyone else also will get benefited with this. So the first question's answer is rare exposure and incidence is high. I will give you very simple example where we are also getting into it. Like suppose if I am working in emergency department where the inflow of patients are too many, and I'm in a rural area and lot of patients, lot of emergencies are coming to me. I have no time to put on my gloves and take off my gloves and keep on changing my gloves and mask and all my apron or whatever you want to say. We are using it during emergency, right? Wearing of apron, green apron, you can say. Now, I'm at high risk of developing HIV. So even if it's a rare exposure, not everybody is getting exposed because I'm giving IV, I'm giving injection and they are on emergency. Maybe I have to give intracardiac and not that I have got a lot of time to keep on saying, oh my God, let me put 2 gloves because maybe he's HIV positive. He has come in emergency, no time to go for blood test and wait for the result. It means the exposure is rare. Not everybody is getting exposed to this kind of exposure. And HIV, maybe we cannot detect immediately. The person is coming and I know he is HIV positive unless he's going for the test and the result is coming, which has a lot of time, right? We have to take some time to do that. So this is the example for rare exposure, but incidence is high. All right. For your second question, of course, usually nobody is going beyond 20 years. Sometimes researcher is also no more if they are starting at old age. All right. So nobody is going beyond 20 years. Usually 15 years. But only thing, When you are starting your cohort study, you decide that time only that my study is for 10 years, my study is for 15 years. You cannot say, okay, 5 years I'm doing the study, now I think I am not getting much result properly, so I continue for 10 years. No. When we are taking from the participants the signature that my studies for 10 years, are you there for 10 years? Okay, unless death has occurred or something else, some unavoidable circumstances has occurred, they will sign for you. So you have to decide first only when you start cohort study whether you are doing for 10 years or 15 years. Okay, so there is no hard and fast rule that you should stop for 5 years, but you can decide I want to do only for 5 years. Then you have to stop at 5 years. Okay.
So
I
the
hope you
time,
answer. Yeah.
the time duration of cohort study is depend on the researchers. Yeah.
Yes.
Thank you,
Research,
Professor.
yeah, researcher, yeah, thank you. Researcher and also the outcome of the disease what we are studying. Yeah, so he will decide. Thank you.
Thank you, Fahri, Prof. Sujata. And then next questions. Okay. Masih ada pertanyaan? Okay, I think it's enough.
I hope I am clear to everyone, whoever asked the questions, because questions were really good and well thought of. Because if we are doing this cohort study beforehand, only it should be clear. So it's really good question, I must say. But I hope I have been able to answer.
Okay, it's very clear and detailed from your explanation, Prof. Sujata.
Thank you so much.
Okay, then that is the end of the Q&A session. So we have learned about the cohort studies. This is a longitudinal study where representative groups of peoples who exposed and non-exposed are followed. It can be prospectively or retrospective. Okay, it has many advantages because it can describing the incidence and natural history of disease and finding association between purposes, risk factor, and health outcome. But it has also some drawbacks because it's not suitable for rare disease, and then it can be expensive and need a long time. Okay. I think we have entered our end of the session. I apologize if there is a coming in the implementation of this event. Thank you again, Prof. Sujata.
Thank you very much.
To the students, to the lecturer from Indonesia or students from Malaysia, may we all get blessings and the strength to face the days ahead in the middle of this pandemic. See you in the second series of this lecture. Okay, I will share the field to the G form to get the certificate to attendance. Okay, thank you. Thank you so much, Professor Sujata. See you.
Welcome.
Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam
Waalaikumsalam
warahmatullahi wabarakatuh.
wabarakatuh.
Thank you.
Prof. Sujata.
Yeah. Can I leave? Can I leave the meeting?
Okay. Yes.
Yeah.
Yes.
So thank you so much to all of you who participated, and also special thanks to Dr. Neneng for conducting this session. Thank you so much.
Okay. Thank you.
Thank you. Bye bye.
Oke, ini yang masih gabung. Thank you Yaid, Fahri. Siapa ini yang siap jadi moderator berikutnya?
Fahri, dokter.
Fahri.
Dokter, izin bertanya nih, linknya belum bisa dibuka, dokter.
Oke, sebentar.
Oke, Bu Ning, aku izin live ya.
Iya.
Thank you.
Oke, Bu Indri besok ya.
Kamis ya?
Kamis.
Jam 10 kah?
Sama.
Jam 9 waktu kita.
Oke, siap.
Iki linknya dong bisa, Mbak.
Sebentar,
dong bisa, Mbak.
Mas Ari
linknya
yang...
coba.
Makanya Mas Ari ini apa nggak standby ya, Mbak ya? 2 HP-nya nggak anu semua itu? Nggak respon itu?
Iya. Ya sudah, ditunggu dulu.
Ini link
anu
udah
aja.
confirm ya?
Nah, nggih.
Okay.
Anu aja Bu, nanti disesuaikan info Bu anu dari Bu Iin suruh yang di presensi di Zoom suruh bikinin sertifikat semua gitu tanpa harus mengisi link gitu, Be.
Nggak apa-apa. Juga peserta.
Yeah. Makasih Bu Tina. Assalamualaikum semua all.
Waalaikumsalam warahmatullahi wabarakatuh.